As we can see in this diagram, there is central insertion of the umbilical cord. Now, if this umbilical cord is inserted on the margins of the placenta, as we can see in this diagram, in the margins of the placenta, then it is called a Battledore placenta. And it derives its name from the game like badminton, which uses a racket, and this insertion of the placenta makes it resemble to that racket. So, Battledore placenta. Now, in this, the shortest distance between the cord insertion and the placental edge is less than 2 cm. And the incidence of Battledore placenta is more in cases of twin pregnancies, where it is somewhere around 24 to 33%, and in singleton pregnancies the incidence is 7 to 9%. Now, in most of the cases, these Battledore placentas are asymptomatic. Now, in most of the cases, these Battledore placenta are asymptomatic, but they may result into IUGR, preterm labor, decreased birth weight, and if the placenta is low-lying, then during delivery, this marginal cord insertion may be compressed, leading to fetal distress. Now, let's talk about the next type of placental abnormality, and that is extracorial placenta. What is it? Normally, the chorionic plate, that is the fetal side of the placenta, and the basal plate, that is the maternal side of the placenta, both are equal in surface area. But if the fetal side is smaller than the maternal side, then it is called extracorial placenta. And how do you remember it? The basal plate is bigger, BB. Now, as the fetal side is smaller, so it is surrounded on all the sides by the maternal side of the placenta. And this surrounding can be of two types, and according to this, the extracorial placenta is also of two types. It can be circummarginate placenta, in which the surrounding of the maternal side around the fetal side is very smooth. As you can see in this diagram, the transition between the maternal side of the placenta and the fetal side of the placenta is very smooth, and so it is called circummarginate placenta. We will understand this again by this diagram. This is a normal placenta where the maternal side and the fetal side, they are equal in surface area. Whereas in circummarginate placenta, the maternal side is bigger or the fetal side is smaller, but the transition between the maternal side and the fetal side is very smooth, and it is circummarginate placenta. Now, if this transition is not very smooth and there is a fold of fetal membranes forming a thickening, valve-like thickening all around the fetal side, it is called circumvallate placenta. Valve-like thickening in circumvallate placenta. And the same thing we can see here in this diagram. The maternal side is surrounding the fetal side, and there is fold of the membranes around it, which forms a valve-like thickening. The next important point is that in circumvallate placenta, the fetal side is slightly depressed as compared to the maternal side. And if you see in ultrasound, this fold of membrane appears as thick linear band or a shelf-like structure. And this type of placenta leads to increased risk of abortion, APH, IUGRs, preterm labor, retained placenta, and increased watery vaginal discharge, which is also called hydorrhea gravidarum. Now, moving on to the next type of placental abnormality, it is Placenta Succenturiata, and in this, a small part of the placenta is separated from the rest of the placenta, and a leash of vessels connects the mass to the small lobe, as we can see in this diagram. Here we have the small lobe separated from the main mass of the placenta, and both are being connected by leash of vessels. Now, similar to this Placenta Succenturiata, we have another type of placental abnormality, which is called Placenta Spuria. In this also, a small part of placenta is separated from the rest of the placenta, but the difference is that there are no communicating blood vessels. As we can see in this diagram, this being a normal placenta, This is placenta spuria, where a small lobe of the placenta is separate from the main mass and there are no connecting vessels. And it is assumed that this accessory lobe is developed from the activated villi on the chorionic levy. Usually the chorionic levy, it is a smooth part lying adjacent to the decidua capsularis. But a part of placenta, if it is formed from the chorionic levy, it leads into this type of placental abnormality, placenta spuria or placenta succenturiata. Now, the next type of placental abnormality is also similar to this, which is called placenta bilobata, and in this the separated lobe and the main lobe, they are of equal size and connected by blood vessels like placenta succenturiata. This type of placental abnormality is also called placenta bipartite or placenta duplex. As we can see in this diagram, now this being the normal placenta, this is placenta bilobata, where both the lobes are equal in size and they are connected by a leash of blood vessels. Here also you can see this. Now, these type of placental abnormalities, they are usually diagnosed post-delivery. If the entire placenta comes out, so by examination, you can easily know that this is placenta bilobata or placenta succenturiata or placenta spuria. But what happens in most of the cases, that the accessory lobe might be left behind in the uterus, and this might lead to primary or secondary PPH. Primary PPH, that is, if just after the delivery this lobe of the placenta is left behind, it will lead to gush of blood, and when we do the uterine exploration, we are able to find this extra lobe of the placenta. If this retained placental lobe remains as such after delivery, it might lead to secondary PPH later on, or it might lead to uterine sepsis or polyp formation. Now, the next type of abnormality that we are going to talk of is fenestrated placenta, and in this a central part of the placenta is missing. As you can see in this diagram, the central part is missing, and this defect usually involves the villus tissue within the chorionic plate. Now, the next type of placental abnormality that we are going to talk of is a rare placental disorder called placenta membranaceae, and in this the placenta develops from both the chorionic frondosome as well as the chorionic levy, and because of this the placenta becomes unduly large and thin and is characterized by the presence of fetal membranes covered by the chorionic villi. Now, what do we mean by this? Normally, the fetal part of the placenta develops from the chorion frondosome, which is towards the decidua basalis, and the chorion levy, which is towards the decidua capsularis, it becomes smooth. But if the placenta develops from this side also, then it is called placenta membranaceae, and this results in the placenta being unduly large. You can see there is a large placenta and it will become very thin, and it is characterized by the presence of fetal membranes covered by the chorionic villi. The fetal membranes, that is the chorion, will be covered by the chorionic villi, as we can see in this diagram. This is the large placenta. Now, in this placenta membranaceae, the characteristic clinical manifestation is recurrent painless vaginal bleeding during pregnancy. Recurrent painless vaginal bleeding. And since this placenta is very large, there might be encroachment of the some parts of this placenta into the lower segment, resulting into placenta previa. And as we have told that there are recurrent painless vaginal bleeding, so which is called APH. The next complication that it may result into is that due to imperfect separation of the placenta, it might lead to PPH. There are increased risks of chorioamnionitis, fetal growth restriction,